everyone. My name is Olivia Jacquemart. I am a QA and trainer with ViaQuest Psychiatric and Behavioral Solutions. And today we are going to be going through clinical health medical necessity for supervisors. So before we start, please make sure you've already watched the new hire medical necessity video or the annual renewal of this training. This one in particular is just going to be what to look for as a supervisor. So if you've not already done so, please watch that video first and then return to view this one. So before we get into the training, we need to know what we are even trying to learn. So for the purposes of this training, we will mostly be focusing on how to assess client charts and what to look for when going over your supervisee's documentation. And getting specific here, other objectives today include defining clinical documentation and medical necessity. We want to identify the regulatory requirements as they relate to clinical documentation, describe the necessary components of a mental health assessment, and evaluate the role of documentation in treatment planning. We also want to be able to describe how to properly create progress notes and the importance of justifying medical necessity. We want to identify the process and necessary parts of discharge summaries and learn strategies to mentor supervisees in medical necessity and clinical documentation skills. Then we have these objectives that are good for practical application. So we want to use the clinical documentation process for successful note writing and treatment planning, demonstrate how to translate your work into the behavioral language used by insurance companies, and apply the golden thread to justify medical necessity. So we focus so heavily on documentation for several reasons. First, it is incredibly important to the regulatory process and is a requirement for meeting regulatory standards of practice. These standards are set by the state of Ohio, and all behavioral health providers are required to meet them. Clinical documentation is both a tool that guides the treatment process, as well as justifies the efficacy of the treatment process. The documentation aids in measuring the outcome of services via things like the PHQ-9 for depression and GAD-7 for anxiety, but it also provides the content required for the client's clinical charts or legal medical record. The content of that chart is what justifies the treatment we provide and is essential for patient care, accreditation, and reimbursement purposes. We always are looking back at the regulating and governing bodies when we look for medical necessity and our clinical documentation. So insurance companies are regulated under federal and state guidelines and regulate their providers under the same standards. Standards and regulations are administered and monitored through insurance companies, and 99% of services are billed per Medicaid and Medicare. Insurance regulations are directly related to higher levels of governance, including federal, state, and even local governments and accreditation agencies. In Ohio, there are 5 managed care programs by which we meet insurances under CMS regulations. An example of an accreditation agency is CARF. VPBS is CARF accredited and follows their regulations. CARF is the Commission on Accreditation of Rehabilitation Facilities, a national agency that requires strict adherence to their standards. We maintain a 3-year accreditation, which is the highest level of accreditation that a company can receive. And we keep talking about medical necessity, but what is that? So here we are referencing the Ohio Administrative Code 5160-101, which is the Medicaid medical necessity definitions and principles. So medical necessity includes healthcare services that a healthcare provider exercising prudent clinical judgment would provide to a patient for the purposes of evaluating, diagnosing, or treating an illness, disease, or its symptoms, and that are in accordance with the generally accepted standards of medical practice. So the generally accepted standards of medical practice include standards that are based on credible scientific evidence, published in peer-reviewed medical literature, and generally recognized by the relevant medical community. The services are consistent with views of physicians and healthcare providers practicing in those relevant clinical areas. The services should be clinically appropriate in terms of type, frequency, extent, site, duration, and delivery setting. And this should be appropriate to the adverse health condition for which it is provided and is expected to produce the desired outcome. So the service is considered effective for the patient's illness, injury, or disease. Continuing here with the OAC, it is the lowest cost alternative that effectively addresses and treats the medical problem. It provides unique, essential, and appropriate information if it is used for diagnostic purposes, and is not provided primarily for the economic benefits of the provider, nor for the sole convenience of the provider or anyone else other than the recipient. Really, to sum it up, it's really any healthcare services provided that are clinically justifiable. All healthcare providers need to be able to show that the services they're providing for clients are in line with those general standards of practice, are evidence-based, and appropriate for the client's diagnosis and symptoms. We need to be able to show that the services we're doing with clients can reasonably be expected to benefit them through reducing their symptoms or increasing their overall quality of life, and aren't being provided just so we can say that we're providing a service. In order to show medical necessity, there are a few things that we need to make sure the client has. So the client must demonstrate symptoms consistent with a primary DSM-5 diagnosis of a psychiatric disorder. They should also be motivated and engaged, agree to comply with treatment plans, and have a system in place to ensure follow through with that plan. Clients must have an impaired level of functioning in areas such as self-care, work, family, living, and any social relations, and outpatient care will help increase the level of functioning. The client should also maintain a current level of functioning through outpatient treatment. And clients will experience increased intensity or duration of symptoms with the diagnosis of mental illness and or substance use without treatment. So these are things that must be present to show that medical necessity. Please look for these factors as you're reviewing those client charts. And clinicians should write chart notes that they would feel comfortable sharing with the client. So some providers will also participate in collaborative or concurrent documentation in which the progress note is completed with the client, that collaborative writing. So just a quick note on collaborative or concurrent documentation. It's called collaborative because we are required to collaborate with the client. And also, we need to make sure that we are doing this in just the last 10 minutes of the session. We shouldn't have our computer open during the whole session. And conversely, the information referring to risk of any kind must be well documented, and safety plans must be completed correctly. These must be present and accessible to the whole treatment team. Our safety planning is also a part of VQ policy. So where a safety plan is required if there's a risk of any kind. So when looking over notes, ensure that facts are written in an objective and neutral manner, staying away from anything opinionated and any unprofessional wording. So a few guidelines to keep in mind for yourself and your team. Only keep one set of notes to keep things organized. You want to avoid any subjective statements or opinions. An example of a subjective statement would just be saying, the client was angry. Well, how do you know that? So as is, it's just an opinion. To be included in a note, it should be justified by stating that the client reported that they felt angry, or adding the phrase as evidenced by, and including whatever details cause you to objectively see the client was angry. So it could be their tone of voice, it could be any kind of use of profanity, what their volume was. So it can be helpful to use those client words whenever possible. We then want to remove any judgmental language from documentation and avoid any labeling that is not their diagnosis. So an example of labeling and using that judgmental language could be something like, the client is lazy and will not help himself. Well, that's not really true. So it could be something like, this clinician has observed that the client is struggling with a lack of motivation secondary to his diagnosis of major depressive disorder. As supervisors, when you are reviewing notes, if you notice any of these bad practices, please address it immediately with your staff. And as we continue through this training, you'll hear me reference the golden thread, many times. This means that every element of the therapeutic process, from intake to discharge, must be clearly documented so that the connection between all aspects of clinical work flow logically from one record to the next. I always love to explain it as it is the tying of all relevant information across all documentation, literally threading everything together. So symptoms and the diagnosis are identified in the psych eval or the diagnostic assessment, which is used to create the treatment plan, which is referenced back to in each progress note. Each element provides evidence and support for the next. This process, on top of contributing to a complete record of client care and organizing client care in a logical and helpful way, also ensures that audits will be passed and increases the likelihood that our services will be reimbursed by insurance companies. So at ViaQuest, we have two types of clinical recommendation documents. One is the diagnostic assessment coming from the therapist, and the other is the psychiatric evaluation or the psych eval coming from the nurse practitioner. In order to provide clinical services, one of these is required to be done first. These documents actually provide the clinical recommendation for services and diagnoses for the client. So all of this is what justifies the services we provided going forward. The diagnostic assessment, DA, or the psychiatric evaluation, PE, forms the basis for any and all work done with the client. So these documents are giving a global perspective of those presenting problems, an overview of what treatment should include. There's a basis for diagnostic formulation or the justification for a diagnosis. It identifies early treatment needs and aids in the ISP or individualized service plan, care plan, treatment plan development, as well as assesses the client's mental health history and current level of risk, whether it be to self, others, property, whatever it might be. And next, we're going to take a look at the presenting problem and diagnosis. So the presenting problem should include the initial symptoms of a mental health issue for which a person seeks help, as well as basic information about them, such as their name, age, gender. So we need to make sure to have the diagnosis, symptoms, and the behavioral examples of the symptoms. And this then equals the presenting problem. So for an example, the diagnosis could be major depressive disorder. The symptoms or diagnostic criteria, so it could be things like disordered sleep, any kind of somatic symptoms, irritability, trouble focusing, as well as what the level of impact that may be. So what's the frequency, what's the duration, what's the intensity of those symptoms. So as a supervisor, there are some things that you will need to be aware of that may be missing when it comes to the presenting problem. So what other symptoms have they experienced, such as depressed mood or hopelessness? And how long have they been experiencing these symptoms? What's the actual length of time? And things to keep in mind when reviewing either the psych evals or the diagnostic assessment. So the symptoms must support the diagnosis. The client must have enough symptoms to support the diagnosis. For some diagnoses, there must be specific criteria within the list to justify that diagnosis. Make sure to work with the person who is diagnosing if you are unsure of those requirements. And some reminders here, it's imperative that a client's symptoms are notated thoroughly because this is what justifies us providing them with those outpatient services. The assessment or evaluation could also include recommendations for ongoing services the client might need upon discharge, so we are actually setting the client up for success. Independently licensed staff do not require a sign-off on documentation, but dependently licensed staff do require a sign-off from an independently licensed staff member. Dependent staff should submit documents that need signed off on within 14 days of the effective date, and this way it gives time for the independent staff to review and send those corrections as needed. Dependently licensed staff will then have 5 days to make any edits and the independently licensed staff needs to sign off on the document within 30 days of submission. So clinical supervisors, just please be mindful that they are signing off on documentation within 30 days so supervisees can continue to provide services. For any more information regarding sign-off, please refer to the clinical sign-off training. So some red flags or things to be mindful of include those adjustment disorders. So these are short-term diagnoses which can make billing difficult in the long term. Any unspecified disorders, as we should be specific about what we are trying to treat and why. And then symptoms and the treatment must support the diagnosis. So we need to be on the lookout for any incongruent items like a 15 on the GAD-7, but no anxiety diagnosis, or a lot of anxiety symptoms reported with a depression diagnosis. Next up, we will be going through treatment planning. First, what is needed in the treatment plan? So some highlights from this list include that basic personal information, things like name, gender, date of birth, and then the diagnosis or presenting problem. And please make sure to reference the most current diagnoses in the psych eval for those updated treatment plans. We need at least one goal with one objective, what interventions or services we will need to be providing for the client, as well as the rest of what is on the screen. Once the treatment plan is completed, we also need to have the signature of the author, an independently licensed staff if that is needed, and the date it was done, as well as signed. One of the first things that we should be seeing and doing when we get the treatment plan is going to be the client's SNAP. This is their strengths, needs, abilities, and preferences. So these should always be filled out in its entirety, and nothing should ever be blank. So in the initial ITPs or the initial treatment plans, it is okay for this to not be as fleshed out since we are just getting to know our clients and what their SNAP is. However, as we get to know our clients on those further ITP updates, these should be getting more and more details in them, especially making sure that we're adding into those strengths and abilities. And if preferences was previously none, we want to see what preferences have formed. And next, we're going to be looking at the treatment plan and the goal. So this is the overview of the big umbrella, what we are striving for in treatment. So what are your best hopes for treatment? What would indicate goals were met or services are no longer needed due to decrease in symptoms or improvement in functioning? What would tell you you do not need me anymore? So this is what the client wants to achieve. The happy ever after ending of the story. It is a state of being that is passive, not active. The goal can be written in the positive or the negative. However, if we can, we always want to keep it in the positive as much as possible. So some examples of client goals include, I want to feel better. I want to stop feeling so anxious. I want to make more friends. And just as a reminder, you need to make sure to get the client's goal, and that is reflective of the informed choice. They should know that we are there to actually provide mental health services. So here we have an example. So we can see that we have the goal twice. So first, I've already mentioned the client goal. We want both a client goal there, and we want to make sure that we have a clinical goal to attach to that. So our example, the client goal, Tess wants to decrease her depression symptoms, stating, I want to feel better. And making sure we attach the clinical goal. The clinical goal is to alleviate the depressed mood and return to the previous level of effective functioning. So first you have the client goal that you will have to fill out in the client's own words. And we can see that as part of the clinical ITP, there are options available for you that are already filled out for you. So to help you restate the client's goals in clinical terms, you can just choose the most apt clinical goal from the drop down. If you like one of those in particulars, you can just select the most appropriate option. And if you do not like any of the options, there is an other in which you can just write your own goal. So this is what the treatment plan looks like in our smart care system, our electronic health record. First and foremost, always making sure we have the client goal. and then corresponding with the clinical goal. And then we have the objectives, which is then going to be more specific. It is what the client does to achieve their goal. It is written in the active, so we're actually using those active verbs, and it is always written in the positive. So we'll look at a good example of this on the next slide, as it should tell me how much, how often, and according to who. So this objective needs to follow the outline of a SMART objective. So we can actually measure, are they utilizing at least 3 self-care tasks with timely or time specific? So that's going to be 3 self-care behaviors per week. And then how do we know? Per that self and support report. So we are making sure that this objective is that SMART objective. It is specific, measurable, achievable, realistic, and timely or time specific. And it is explicitly related back to the client's diagnosis. So the test will decrease those depressive symptoms. So that is super important. If we can't measure an objective, how do we know if they're actually making any steps towards their goal? And here is what an objective looks like when you do the clinical ITP and SMART Care. So as part of the goal objective section, if this is an updated clinical treatment plan, we need to make any notation towards that progress. So we can see the objective there, and for an updated treatment plan, how they're doing. So there has been some improvement, and we have the reason for that rating. Tess has been making some progress as she has been able to identify negative self-talk about twice a week, however, has been struggling to replace this self-talk with those positive adjustments. So she is making some improvement. She's able to identify the negative self-talk at least twice, however, is struggling to replace it with those positive. Here's another example of the clinical progress review. This is a good objective review because it illustrates that she has only partially met the objective. So we can see the objective there. Sally will learn and implement 2 calming and coping strategies weekly to manage challenging situations related to trauma per self-staff report. And there has been some improvement, partially meeting the objective. So continuing the objective, some improvement made. Sally has been able to learn and implement the calming skill of square breathing and uses it daily. Sally notes a sense of calm after completing 4 rounds each morning, allowing her to leave her room to eat breakfast in the dining room with other residents. Sally will continue to work on this objective to learn other calming skills to help her manage challenging situations related to trauma. So she's now practicing that 1 coping skill, but hasn't quite gotten the 2. This justifies the reason for continuing this objective. And whenever a treatment plan is reviewed, progress towards the goals and objectives needs to be documented thoroughly. That is why it is so important we show you those examples and making sure you know exactly what we're looking for. And this is partially why creating those SMART goals and objectives is so important, because it gives us something concrete to track and remark on. Progress review is what provides the justification of medical necessity to continue those services. Providing evidence of medical necessity is an ongoing part of providing client care. It's not just something we do at intake. So this needs to be checked and reviewed by supervisors. This way we ensure that we have justification for the continuation of services. An ITP can be updated before the official policy review date for a few reasons. So minimally, the treatment plan should be updated every 6 months. That is our policy. So the policy is every 6 months. Outside of the policy of minimally 6 months, a client's needs or circumstances may have changed. Treatment plans have to be updated when adding or removing a service if there's been a major consistent changes in frequency of services, the diagnosis, or if there's been any change in treatment needs. Best practice and what is recommended in treatment plan review is every 3 months or 10 sessions for therapy and TBS. The next section of the treatment plan is going to be the interventions. This is where we are highlighting the modality, the frequency, and duration of services. So, is the modality going to be individual, group, or family services? Will you be providing this service daily, weekly, bi weekly, or monthly? Then, how long do we expect this service to last? Is this going to be 3 to 6 months, or 6 to 12 months, a year or more? When reviewing your team's clients' charts, just check that everything is accurate so that the actual services being provided are matching the treatment plan. So again, if the treatment plan states that the client should receive TBS services weekly, please ensure that's actually the case. Here we have an example of the intervention section for the clinical ITP. Some interventions that could be selected on the CITP include the individual CPST, individual psychotherapy, and individual TBS. Once selected, we can see an example of the TBS and psychotherapy intervention where we need how many times we will be providing that service, how often, and for how long. So we can see that there are specifics to what is going to be provided to the individual within those treatment services. So in the details there for TBS, we can see that how many, 3 times weekly for 45 minutes. Tests will be provided with therapeutic behavioral services, including symptom monitoring, coordinated link with services in the community, provided education and advocacy when needed, and additional skills provided, including developing coping skills such as deep breathing and guided meditation, anger and anxiety reduction skills such as the stop practice and distress tolerance, as well as activities and integration in the community to increase communication and social skills. And then for the individual psychotherapy for our therapists, we can see how many. There will be 1 session a week for 75 minutes. Tests will participate in outpatient psychotherapy services to help manage anxiety symptoms. Focus on session includes the processing of past and current events, coping and independent skill learning, behavioral action and control, mood control, engagement and communication skills, symptom tracking and symptom education, which can include evidence-based treatment modalities such as cognitive behavioral therapy, CBT, dialectical behavioral therapy, DBT, and motivational interviewing, MI. And then we want to tie it all together. So when we are doing the treatment plan, we want to make sure that the golden thread is still present and the information is being tied together throughout the entire document. Things to keep in mind as you're reviewing Supervisors' documentation for approval. The goal, this is again the ideal outcome. The objectives should be what the client will do to achieve the goal. The interventions, what the staff is doing as part of the treatment, what progress is being made, and it needs to reflect the problems and goals, what barriers or psychosocial stressors are in place for the client, and lastly, we always want to go through any risk concerns. That way we are ensuring safety. Some other reminders to keep in place. So all treatment plans, regardless of service, are subject to the same policies. Always remember the golden thread when reviewing those treatment plans. Goals and objectives are explicitly tied back to the diagnosis identified in the DA or PE. Goals and objectives should be those SMART goals and objectives, so specific, measurable, achievable, realistic, and timely or time specific. And ideally, we should be getting those client quotes for the client goal and then restating it in that clinical language. The goals still need to be reflective of the informed choice. If the goal is to win the lottery, we should have the discussion with them about what type of services we are there to actually provide. If they want to write a book, we can ask them, what's in the way of you being able to do that? If they say, I don't have the self-confidence to do it, then we need to ask why to get to the mental health issue to work on. If they say, I haven't thought of a good storyline yet, well, that's something that we can't work on. Same thing with it being realistic, to be happy all the time or to live on my own again. If that's never going to happen, then we need to make sure that this goal is actually something that's realistic for them. We should be having that conversation with clients about what's within their ability and within our ability to help with. And we need to make sure that we get those clear mental health symptoms and we are working on the appropriate diagnosis in the goal and objective. The effective date of the ITP should match the date of the first billable service because ITP should be done in collaboration with the client and or client's guardian. And all ITBs should be completed within 3 sessions or 15 days, whichever is sooner, of the first mobile session, and then must be signed off on by a clinical supervisor within 30 days. Please make sure to remind supervisees of these reminders as they're coming directly from the treatment plan policy. And some common errors to look out for when you are reviewing treatment plans include the treatment goal or the treatment plan in general are not mental health related. So maybe it has something to do with medical health or their mobility. The SNAP portion of the treatment plan is often not filled out correctly. So we may be seeing things like none reported, entered where it is not supposed to be. All clients should have strengths, needs, and abilities notated, and nothing should be left blank. The transition and discharge section do not specify those outpatient services. Supervisors should be mindful that the effective and end dates are correct, and the effective date should always match the date of the service. So if this is the very first treatment plan, it should be the same date as that first billable service. For therapy and TBS, the target date should be 6 months from the effective date, and end dates are going to be 1 year out from the effective date. Objectives and those objective review then. So the objectives should be the SMART objectives. And we also notice that objective reviews often do not justify the continuous medical necessity. We're seeing objectives that are too varied with too many activities. There should only be one thing per objective. It can be helpful then to just create multiple objectives to allow for flexibility versus trying to put everything on a single objective. Here we have examples of some of the common errors you may be seeing on the individualized service plan. So first, again, those effective dates. The effective date needs to match the date of the billable service. And when the treatment plan was gone through with the client is the effective date. So the date that you're actually going through and reviewing the treatment plan with the client is the effective date. The estimated discharge date needs to be 1 year out from the effective date. So over here, we can see our effective date, 6/17/2025, but the estimated discharge date is 8/2/2025. It does not align. So the level of care, we can see this example says outpatient services to include TBS individual therapy. However, our level of care section needs to establish what services are being recommended for what diagnosis and by what licensed professionals assessment. Also, TBS is not a therapy program. And in the bottom example, we can see that there is no mention of the actual level of care. We need to clearly outline that we are completing outpatient services. Outpatient is the level of care VPBS provides. The last example we are showing here includes the intervention section. So the example of the TBS intervention here needs to include the actual details of the intervention being provided, not the frequency of the service. And then the duration and frequency of interventions on the treatment plan need to match the services that are actually being provided. So if the treatment plan specifies that this client will receive one 1 hour long session each week, we should not be seeing notes for multiple sessions each week or short half-hour sessions. If some kind of client barrier is causing this, then the treatment plans need to be updated to reflect this. Then the treatment program section. So the assigned for contribution should only be selected yes for those clinical services. So if they're receiving therapy and TBS and not nursing and psych services. Then the contribution completed also needs to be checked for the service to be pulled through accordingly in Smart Care. So state psych and nursing, they have their own treatment plan, so we do not need to put them on the clinical one. And then next up, we are going to be getting into our progress or session notes. So when we talk about session notes, this is what we mean. The notes document or assess the contents of a conversation during an individual, group, couple, or family session. They must clearly relate to the mental health objectives and goals of the client. So we are always working on and tying things back to the goal. These documents can be a standalone document regarding medical necessity. So that means that we need to be able to show medical necessity within each individual document while continuing the golden thread of medical necessity across all documentation. So with there being identifying progress with a clear link to the treatment plan, and these notes are part of the client's legal clinical record. When looking over session notes, please verify that the information is correct. We need to make sure that the client's name and number or the client ID, the type of session, so the program and procedure, location, and this is an important one as we are seeing that location is often not selected correctly for things like phone calls. Whenever a phone call is billed, the location should be selected as the regional office. So we need the correct date of service, the time of service, appropriate mode of delivery, whether that be face-to-face, telehealth, or that telephone. If there are any others present at the session, which we are also noticing is not notated correctly, if there are others present, make a note of it. And we need the diagnosis. So we are continuing the golden thread and medical necessity. Lastly, any add-on codes if it is applicable. Now we have what is needed within the session note, which includes the services provided, so therapy, CPST, TBS, the goal objective being addressed, a completed mini mental status exam, the risk assessment or lethality section, clinical interventions the staff did in session with the objective findings, so what the staff observations are, and those subjective findings, what the client's perspective is. We want to verify medical necessity of session, so these should not just be social visits, right? If the activity was the client was talking about family, pets, vacation, favorite color, or playing cards, the idea is that by talking with the TBS about that, or by having someone to play cards with, that is what is alleviating the client's symptoms. It's not helping the client get to a place where the TBS or therapists aren't needed anymore. What is helpful with verifying medical necessity is making sure that this language is tying back to the ultimate goal and making sure we get them to a place where they don't need our services anymore. And we also need help in forming appropriate clinical language. So you didn't play cards, you engaged in a card activity aimed to blank, decrease depressive symptoms, whatever it might be. There should be documentation of what the point of playing cards was. We then need the client progress towards the goal and objective and what was completed in the session. We need a plan of how to address those barriers and what homework was given to the client or others. And lastly, we need to have the signature with credentials and the date it was signed. Some general things to look for when reviewing notes. We want to use the client's name as well as complete sentences and correct spelling and punctuation, grammar, all that fun stuff. As part of the clinical team, do not use abbreviations. It will make things easier, and it's just best practice to always write out items. Best practice for documentation is to do documentation concurrently, that collaboration, or within 24 hours. But it is VQ's policy to have documentation done by 48 hours. The collaborative or concurrent documentation or working with the client on the progress note is, again, that best practice. And be ethical. So ethics are a system of principles or rules that guide us in this professional context. Notes should be original and no copy and pasting. This is a major red flag for insurance companies. And reviewing notes, please look at more than one. This is the only way to know if your supervisee is actually copy and pasting from one note to the next. Always think about that golden thread rule. So if it's going from the DA or the PE, and that's tracking to the ISP, and that is tracking then into progress notes. You want to consider the impact of the note being read aloud in court if it is subpoenaed, because again, these are legal medical records, or the client reading it themselves, which is, I know, why a lot of people enjoy collaborative documentation. The client knows exactly what is going into their chart. And we want to be mindful of how to avoid any false, fraudulent, and bad billing practices. So if you're billing at the same time as a coworker, you will get a warning. Please pay attention to this warning. as it can help us avoid any of bad billing procedures. We want to ensure to bill for those exact times. We are not rounding. If the session ends at 11:13, it ends at 11:13. It does not end at 11:15 or even 11:20. Providers who are consistently billing those exact times are more likely to be flagged for fraud by insurance companies. Every session is going to be unique. We want to document who, what, where accurately and be consistent and pay attention to careless mistakes, such as incorrect place where the service took place, so the incorrect location of where a service took place, or the mode of delivery. We want to be sure to double check your and your supervisee's calendar appointments to avoid any of these minor errors. By being accurate, we are also avoiding any kind of vague note writing. We mean here any kind of generalized statements that really could be applied to anyone. This appears as that copy and pasting, and we need to make sure that in each note, each session is unique to that individual client. So when looking at your supervisee's documentation, we need to make sure that we are checking for medical necessity. So is there evidence of medical necessity? Was this session actually necessary for the client? Are the interventions performed in the session on the client's treatment plan? Are we meeting with the client for an actual reason? We need to make sure that all those notes are person-centered. So can the reader actually gain a clear understanding of the client's experience of this session? We need to see that there's justification for the session length. Do the interventions described in the body of the note make sense for the length of the session? We need to see the goals and objectives. Do the goals and objectives on the client's treatment plan address the symptoms identified on their diagnostic assessment or the psychiatric evaluation? If we are working on things in session that had nothing to do with the treatment plan or goal, then this is not showing the golden thread and is not medically necessary. We cannot bill for things not on the treatment plan. And just some other various note tips here. We cannot bill for any kind of transportation or just idle time, just waiting around. It is not a billable service. And all progress notes should include an intervention that is related to the client's ITP and diagnosis. For TBS and CPST notes, this means that at least one of the 10 interventions is required to be selected within each billable note. So again, as supervisors, you should read more than one progress note per client to review for any trends, copy and pasting, repeats, anything like that, as well as look for just common errors such as a wrong name, grammar, or even spelling. In the progress note, you are making sure to attach at least one goal and one objective during the session. This isn't to say that every goal and every objective are required to be selected. We just need to make sure at least one of each is selected. Then you are able to determine how they think they are doing with the client. So anywhere from they've achieved this goal to there's been an increase in symptoms. However, that note does need to justify that selection. So we should not be seeing that there is some improvement selected, but the person is isolating or experiencing an increase in symptoms further within the progress note. Here's what the top of the progress note looks like. So here we can see that the goal and objective are selected with an option on how the client is doing with that goal and objective. And here we have the TBS note example. So this is the client response to the session and how it relates back to the client's treatment plan. So Sally engaged in beginning to create a WRAP, the Wellness Recovery Action Plan. Sally was able to identify several activities which usually help alleviate her symptoms of depression and anxiety: listening to music, taking a daily 15-minute walk, doing a crossword puzzle, meeting her friend for coffee in the dining hall. Sally was able to identify some things to avoid, which tend to cause anxiety and bring down her mood: overeating, staying in her room all day, wearing the same clothes for several days, and watching the news. Sally identified a skill she would like to try, stating people taking the chair yoga class always look so calm. I could probably do that and feel less anxious. Sally was able to identify what it is like when she's well, stating, I shower, do my hair and makeup, and I feel like socializing. I call my friends and family and return emails. I leave my room to attend bingo and art class. I like to play cards and other games in the activities room. I get up, eat breakfast, and go for a walk. I read my Bible and do my daily devotionals and prayers. When I am depressed and anxious, I don't do those things anymore, and I am like a different person. I don't talk much. Sally reported a decrease in anxiety by the end of the session and stated, I feel a little relief from worrying, knowing better what to do and what not to do. So, as a supervisor, things to look for include the medical necessity by mentioning diagnosis or symptoms, a clear description of the interventions being provided in the session, as well as the way the client engaged in them. It should be person-centered, such as using the client's name and including quotes as much as possible. And lastly, these things should be stated objectively. So we can see how Sally here participated in the intervention. There's a mention of the objective findings of Sally's anxiety and depression, which leads to the medical necessity. It's person-centered as well, as there are quotes from the client regarding mood and reasons behind an increase in symptoms. There's a clear flow from the beginning of the session through to the end. Here is the therapy example note. So this in particular is the focus of the session, which focuses on what the therapist did themselves within the session and what interventions were done. So today's session focused on processing emotions and triggers affecting the client, reviewing symptoms, providing empathic responses, unconditional positive regard, and validating feelings and emotions for the treatment of generalized anxiety disorder and major depressive disorder. Clinician and Sally explored her current relationships, identified her emotions, communication styles, and implementation of assertiveness, including setting healthy boundaries and saying no as necessary. Clinician and Sally reviewed self-report of Sally practicing and using the CBT mirror technique taught previously in session, involving creating a positive self-affirmation to use while looking at herself in the mirror to help with reducing depressive symptoms and improving self-esteem, self-worth, and self-confidence. Clinician and Sally reviewed her self-report of practicing and using the relaxation technique of deep breathing and the mindfulness grounding technique, five senses, in session to assist with alleviating anger and anxiety stress symptoms. Clinician encouraged Sally to continue to engage in tasks that would increase coping skill utilization to decrease symptoms of generalized anxiety and major depressive disorder. So for these therapy notes, the evidence-based treatment modality needs to be noted explicitly in the body of the note. And these items in particular that we are focusing on is going to be the redirection to the diagnosis of the client, the generalized anxiety and major depressive disorder. There's self-report and person-centeredness within the quotes and note using. Then there is the intervention that was used and why. This is the second part of the therapy note example, which is the client's response. And this is how the client responded to those therapist interventions. Here we can see that Sally was friendly, cooperative, and engaged through today's individual psychotherapy session. Sally reported that she has been trying to practice positive self-talk and saying positive affirmations to herself using the mirror technique as practiced previously in session. Sally reported it helps at times with depression. Sally reported she would continue to practice this technique, as she reported it does help when she is able to think more positively about herself and the events in her life. Sally reported she would work more on practicing deep breathing as a relaxation technique and the five senses grounding technique as practiced again in session today to help with reducing anger and anxiety symptoms. Sally reported staying busy with hobbies like playing games, coloring, and spending time with family also helps with reducing anger and anxiety. Sally reported she is doing better with assertiveness and setting boundaries and reported, I think this has helped me feel better since last time. Sally was receptive to praise for her progress made. Sally reported feeling today's session was helpful in allowing her to practice deep breathing and grounding techniques again to use in distress and to reduce anger and anxiety symptoms when her hobbies are ineffective. Sally agreed to continue practicing these coping skills. What we are looking for within the client response, we can see the quote, the relation to depression and anxiety. We can see how the client completed the coping skills and the importance of how completing the coping skills reduces the symptoms of anxiety and depression, as well as the plan and what to continue doing independently. An important aspect of the progress note is the mini mental status exam. This includes emotion, thinking, behavior, medical condition, and substance use. This is based on clinical observation and client report. The items that we want to assess include what their mood is like. So a patient can describe it in their own words, rank on a 1 to 10 scale, what their internal feeling is, and then their affect. So this is going to be something that you are seeing objectively, externally. So you're describing what type it could be. So they could have a depressed affect, sad, anxious, angry, euphoric, what the range was like. Is it full? Is it restricted or blunted? As well as appropriateness to the content and congruence with the stated mood. What the orientation is like, time, place, or person, attention, are they actually able to focus on the session? What their thought processes were like, so is it logical and goal-directed, or has there been a flight of ideas with word salad? The perception, so hallucinations and delusions. The general kind of behavior, so is there increased activity with restlessness or agitation? Has there decreased activity? Maybe they're feeling really lethargic or fatigued. What is the eye contact like? Is it avoidant, normal, excessive, and intrusive? Mannerisms, posturing, fidgeting, rapid or slow speech, anything like that. A common error to look out for is that the MSE, or the mental status exam, is not filled out accordingly. It will only be selected none-reported or baseline for clients, and then these items will be described in the body of the note. We need to make sure that if something happened, we are notating it across the entire progress note. The next part of what we are assessing in our session is any risk or safety concerns. This is the ideation, intent, attempt, means, plan, or other of self-harm, harm to others, harm to property, and suicide risk. If you are struggling on any of these items, make sure to reach out to your supervisor for further information. A common error that we see is the lack of use of the other section within these categories. If the risk doesn't fall under the other headings, or if more needs to be added in, make sure to utilize that other area so we're getting all details of the situation. If the client is at risk for any of these factors, or if anything is marked in this area of the progress note, this is when supervisors should check that there's a safety plan present in the chart and that it is filled out correctly. If there isn't a safety plan or it isn't completed correctly, it's important that you follow up on this with your supervisee as soon as possible. If none reported is selected, it's worth double checking that there is no description of these risks in the body of the note instead. And we need to know what clinical interventions are in place. For therapists, it could be CBT, DBT, MI, psychoeducation, or more. And our TBS are able to do the TBS or CPST interventions. This includes ongoing assessment of needs, achieving independence, skill building, coordinating, symptom monitoring, crisis management, advocacy, education or training, mental health interventions, and empowerment. As well as within your note, you also have that 11th option of treatment planning. We want to pay attention the language that is being used by your supervisees when describing those objective findings. So we should be making sure that the notes include as observed by provider or as evidenced by client report or behavior. This goes a long way in determining the objectivity of how the client appears. Some other way we can increase objectivity is by being specific and use those direct quotes when possible. Then those subjective findings, so what the client themselves are feeling subjectively. The client's perspective here is unique to them. So using that quote, we can see here the client report. I got hit by a wave of dread. It hasn't gone away. I hate myself when I feel this way. I only feel better when I talk to my sister. That's a subjective experience for that client. And we want to verify medical necessity and express that we are continuing treatment as it is medically necessary to reduce and stabilize symptoms, prevent decompensation, address those symptoms, manage those chronic symptoms, improve functioning, and prevent a higher level of care from being needed. We always want to keep an eye on the progress that the clients are making, such as what the client is able to do, is not able to do, what they did or did not do, what they gained. We should elaborate on the client's progress towards treatment goals, so that way we can know when they may be ready for a successful discharge. So our client progress example. So again, an objective example here. So clients was able to experience a safe space, allowing him to identify and tolerate some feelings without using distraction as protection. So that is significant progress. And the client gained compassion for his struggle to identify his feelings through continues to struggle with appropriate ways to express them, being slight progress. Here on the screen, we can see Tess meets with TBS staff on a regular basis outside of her room, continues to be open, talking to TBS, and seems to have some insight regarding mental health diagnosis of anxiety. Tess reports it has been observed that she struggles to complete coping skills independently and following her daily routine. Tess reports she wants to continue working on managing her mood and implementing her coping skills to function independently. To the plan and the homework section for the note, we are needing if there is a continuation with the current treatment plan. We want to consider treatment plan changes if updates to the goals or objectives or referrals to other services if needed. Make sure to give homework to your clients or others as it is needed and can assist in further progression in treatment. A common error that we see is that the homework is just being copied and pasted from one note to the next, or that the objective is copy and pasted into the homework section. Each time the homework should be a little different, or if it is exactly the same, why is it exactly the same? For the homework to be effective, we need to explain how barriers and needs are going to be addressed. We need to know how they are going to reach their goal and objective, not just that they are going to. Lastly, just make sure to sign your note accordingly so it can be billed appropriately. So then collateral contact with others are important for a few reasons. Others that are involved in the client's care can provide important information such as treatment planning, aftercare planning, assessment for additional treatment, clinical consultations, treatment coordination, risk management, and discharge planning. A lot of these items can help with clinical justification. A brief summary of goals, objectives, and/or interventions addresses supported or reinforced during this consultation. Now we'll talk a bit about collateral contact notes and look at that example. So collateral contact notes will generally be the coordination of client care with supports, and they require the inclusion of all the elements you see on the slide here. If you are doing collaboration with family, staff, or others involved in the client care, make sure to indicate coordination of client care if the client is not present. This way we can ensure billing does not get rejected. This language is helpful for when therapists as well are not billing for therapy. Billable moments include interactions with those client supports, even if the client is not present for said discussion. As with every note, everything must be tied back to the treatment plan, and the note must provide the evidence of medical necessity. The note should include what type of contact it was, if it was in person, over the phone, or even a fax, the reason for the contact, clear information about who specifically was contacted and what their relationship to the client is, and a clear description of why this contact was necessary to work towards the client's goal and objective. There should also be information about any follow-up that may be needed. Something we're seeing with these notes is that they often lack detail and don't provide that evidence of medical necessity. It should never just be called and left a voicemail. Nothing else. There should be information about who was called, what the content of that voicemail was, a justification for why this was medically necessary, and related to the client's treatment plan. Also, when you review collateral contact notes, please check to make sure that we have a release of information on file for whoever was spoken to. Here we have an example of a TBS collateral note. So please take a moment and pause this video to read the note in its entirety, so we can just see why the contact was medically necessary, as there is a mention of an increase in depressive symptoms and safety concerns that are associated with the client. Again, please pause so you can see what a good collateral contact note looks like in its entirety. And although sessions are only billable if they are over 8 minutes, we still need to make sure that we are doing a progress note. It's important to document that non-billable contact with clients. This supports any kind of need for discharge if the client is not engaging in treatment. It supports clients who are engaged with struggling with other barriers to treatment and has those legal aspects. since this documentation is going to the client's legal medical chart. Remember, if you didn't document it, it didn't happen. And here we have another example of what makes a good non-billable note. So we can see the writer attempted to meet with Tess to follow up on treatment services. However, Tess declined. Tess agreed to check in regarding mental health tomorrow. So it is supporting both the staff member for attempting to see the client, as well as supports the clients for showing an attempt to engage, but may need some extra time. So when completing those session notes, here are all the items that need to be addressed. We need to have the client's perspective or those subjective findings with quotes, the staff observations or those objective findings, how the client appears physically and or emotionally. We need the interventions, what the staff does in session. We need to do the evaluations, such as the MSE, the mental status exam, which explains how the client appears, what the client says, and justifies the intervention. We need to do the risk or lethality assessment, which is all about those risks and safety concerns, as anything such like violence to self or others, to that property, if there has been progress between sessions or during the session. And lastly, we need the plan and homework, what the client or others will do between sessions. These progress notes should be able to be, again, those standalone documents of medical necessity, as well as tie into the other documents, such as the ISP and DA or PE. We then just want to make sure that we are paying attention to how we educate our staff members. So train and educate your staff members in appropriate medical necessity and documentation. So be mindful that you are likely supervising people with a wide range of education and experience. Many employees have a high school education, while others may have a college degree but lack work experience. Try not to use too much jargon and do your best to communicate with your supervisees in a way that they will understand and will be able to actually apply to their work. Provide them with actionable feedback. We also have a team of auditors who assess trends and pay attention to common mistakes among staff members. You should use this information to inform your approach with your supervisees. Be sure to follow up on any corrections with staff members as they're needed. There are already existing trainings and resources as well that you could utilize with your staff members. This includes smart care reinforcement, so being thorough when doing smart care reinforcement to ensure staff members understand the concepts taught in the new hire training. There's TBS University in order to go through how to practice best interventions, activities, and how to practice best writing. And do not underestimate Relias either, as it can provide a lot of good resources and trainings that are available for all staff members. Some other resources that may be present is if your region has treatment plan clinics. This is an excellent opportunity to educate on medical necessity in those treatment plans. You may also suggest outside trainings to supervisees whenever you come across them. Always make sure that you understand medical necessity so you can also explain it clearly to your supervisees. We will be going through a quick coding review here. So first, going through interactive complexity. Interactive complexity is an add-on code for services and is for our therapists only. So it can be added to those different procedure codes, including psychotherapy 90832, 90834, and the 90837. You can also go through group psychotherapy, so 90853. And it is those psychotherapy add-ons for EM services 90833, 90836, and 90838. So interactive complexity refers to specific communication factors that complicate the delivery of a psychiatric procedure and occur during the delivery of service. So common factors include more difficult communication with discordant or emotional family members and engagement of young and verbally underdeveloped or impaired patients. It may also be added when there is evidence of or disclosure of a sentinel event and mandated report to a third party. So it could be in the case of abuse or neglect with report to the state agency, or the use of play equipment and physical devices, any interpreters or translators to overcome barriers to diagnostic or therapeutic interaction. Again, this should not be applied when the client always or routinely requires use of devices or interpreters. It should only be used if it is out of the ordinary and is complicating the delivery of those psychiatric services. So then some of those common errors that may be found with attempting to add interactive complexity include it just not being justified in the progress notes. So no detail including regarding what the interactive complexity is. It is billed for those telehealth or phone call services, as interactive complexity can not be billed for those. Interactive complexity can only be billed for those face-to-face sessions. Then there's no Z code as part of the client chart. It is best practice for there to be a Z code to bill for interactive complexity in order to better justify that add-in code. Here's an example of an add-on of interactive complexity for therapists. So we can see that yes, it was present. What was present with the details, so that within those checkboxes, and it was also added into that add-on codes tab. So we have the actual selected interactive complexity add-on, the start time, and the duration. So then getting into our crisis procedure code. So utilizing a crisis procedure code is used for an urgent assessment and history of crisis state, or the risk assessment, a mental status exam, and safety planning. This includes psychotherapy, mobilization of resources to diffuse crisis and restore safety, and implementation of psychotherapeutic interventions to minimize the potential for psychological trauma. When billing for psychotherapy, we need to make sure that we are using the psychotherapy for crisis 30 or 60 minutes, and it is policy that the therapist needs to complete the crisis assessment within 24 hours of being notified. This means that the CSSRS, the risk assessment, and the crisis plan are required to be completed. Typically, when doing a crisis assessment, it is because the situation is life-threatening, complex, and requires immediate attention to a patient in high distress. The therapist does have to initiate crisis services or codes prior to any TBS services. Some more things to keep in mind include that the time counted towards the service must be face-to-face with the patient and or family, though the time does not need to be continuous. The full attention of the provider, physician, or other qualified healthcare provider must be devoted to this patient or family. The client must be present for some or all of the service. And please reference the crisis and safety planning video for additional information and details for content of billing crisis. If you are confused regarding any crisis services, please make sure to reference that crisis safety planning, as well as the policy core 411, and reach out to your supervisor as needed. Here, we just want to quickly review our discharges. If any billing was completed, it is required for a discharge form to be completed, explaining the client progress and why we are no longer providing services. Here we have what is needed within our discharges, so we need to have the discharge date, the reason for the discharge, the client's SNAP information, the client's response to or overall progress in treatment, what the condition at discharge was, any follow-up recommendations, how the client was informed of the discharge, if this was a letter, a phone, or just in a session. And like with treatment plans, clinical supervisors must sign this within 30 days of it being submitted for approval. One important thing to note is that even if the client passed away, we need to do a thorough and complete discharge of the services the client received. A common issue to be on the lookout for is that the discharges are vague and don't have the actual details of why we are discharging the individual. Again, we need to make sure that we are indicating any progress or lack thereof, as well as the reason for the discharge. So here's our example of an appropriate discharge when someone has passed away. We can see that the SNAP is still filled out fully, accordingly, and accurately based on the client, and has the transition discharge details explained. So test here unfortunately passed away. We can see then an accurate review of progress and what movement towards recovery there was prior to test passing away. Lastly, we are making sure we are detailed regarding why no referral was made. So again, as with our other examples, please pause for a moment and read this in its entirety, as this is a good example and an appropriate discharge of what we were looking for. So some general red flags or things to be mindful of when it comes to billing include first, the need to match the service provided with the definition of the service code billed. The need to match the level of service provided with the service billed, and there should be no overlapping of billing. This means that no one should have billing that is occurring at the same time as another, or the same staff member cannot be billing for two clients at the same time. There should be no cloning or copying of services, and copying and pasting from one note to the next is a big red flag when it comes to billing services. Finally, we need to keep an eye out for any billing of just any undocumented services or services that did not actually happen. Overall, you should be able to guide your supervisees to use this clinical documentation process for successful note writing and treatment planning and other documentation. Demonstrate how to translate their work into behavioral language used by insurance companies and apply the golden thread to justify that medical necessity. Then all practicing behavioral health providers must have a working knowledge of medical necessity to meet those regulatory standards of practice. If you are unsure of any of these aspects, please watch this video again or review within your supervision until you do feel confident. Same thing with your supervisees. Make sure that they feel comfortable with medical necessity as well. That is all that I have for you today. So please, if you have questions, do not hesitate to touch base with your supervisor for additional guidance or watch this or the other medical necessity videos again. Otherwise, have a great day.